Hi engineers, in this video we are going to talk about acute rheumatic fever. We're going to go into detail particularly on the pathophysiology of it. We'll talk about some signs and symptoms and then we'll go into diagnostics. Alright, so let's go ahead and get started. So what is rheumatic fever? Rheumatic fever is an inflammatory condition that can be in response to streptococcal pharyngitis, particularly group A beta hemolyticus streptococcal bacteria. And we'll get into more detail on this. So let's say that somebody gets strep throat. Whenever they get strep throat, their body has a response to that. They produce antibodies against the actual foreign bacteria, mount the immune system, and then try to destroy the bacteria. However, we're going to need antibiotics in response to that, right? So we need to treat with antibiotics. Now, here's the thing. 97% of the population respond properly to it by producing antibodies against the bacteria itself. However, in 3% of the population, they can have this condition where they produce antibodies not against only the bacteria, but against other tissues that have antigens or proteins that mimic the antigens of the actual bacteria. So let's go ahead and start off with this whole process. So what is the most common etiological bacteria that leads to strep throat? That bacteria is called group A beta hemolyticus streptococcal bacteria, but specifically streptococcal pyogenes. Streptococcus pyogenes literally means that it's pus forming. Now, what does beta hemolyticus mean? If you were to take this bacteria and you put it on a blood agar, so microbiology, right? You have like let's say here I have a blood agar plate. And on this blood agar, I have obviously what it says. I have some red blood cells. So here, I'm going to have this all right here, kind of highlighted here in this dark red. I'm going to put some red blood cells there. What I'm going to do is I'm going to take the group A beta hemolyticus streptococcal bacteria and I'm going to put it in here on top of this blood agar. What it would do is you would go back and look at it after it's properly incubated and you would see these white spots. What that means is that the actual bacteria produced a protein, and that protein is called streptolysin. And what streptolysin does is it causes the hemolysis of bacteria, particularly what's called beta hemolysis. So to understand this, group A beta hemolyticus streptococcal pyogenes is a bacteria that causes streptococcal pharyngitis, strep throat. What is this name coming from? The beta hemolyticus is because if you take the bacteria, you put it on a blood agar, microbiology-wise, you let the bacteria incubate, it'll start breaking down the red blood cells by producing an enzyme called streptolysin that breaks down the bacteria via beta hemolysis. There is another process, it's called alpha hemolysis, but it doesn't really break the bacteria down. You can think about it kind of like bruising or just beating up on the red blood cell, but it doesn't completely lyse the actual red blood cell. Okay? Now, what happens normally is we have this actual bacteria. This bacteria has particular antigens on it, okay? These little blue antigens here we call M proteins. They're called M proteins. And these are the antigens on the streptococcal pyogenes that activates particularly our immune system. Now what happens is you'll have this bacteria, he'll start producing tissue damage, right? So he'll start producing tissue damage. When you damage the tissues, what does it do? It triggers an inflammatory response, right? So there'll be the production of leukotrienes. There'll be the production of prostaglandins. There'll even be the activation of mast cells. So you know you have mast cells in the connective tissue. Those mast cells, upon stimulation, will release massive amounts of histamines. And what will this do in response? It'll increase the inflammatory response. It'll cause the blood vessels in the area to dilate and to increase their capillary permeability. So now you'll have more blood flow, right? So this is going to do two things: increase blood flow and increase permeability. The whole purpose of that is if we have more blood flow, we have more white blood cells, we have more complement proteins, we have more immune system structures coming to the area. If we have an increase in permeability that allows for a lot of our white blood cells and complement proteins and immune system molecules to leak out of the capillaries and into the tissue spaces to start breaking down that bacteria. So that's the first thing that's going to happen. Now, after we initiate this immune system response, guess what white blood cell is going to come to the area? This is going to be your macrophage. So there's going to be the macrophage, and there's another cell that comes to the area as well. He's even more in concentration in this area, and that is going to be your neutrophils. Okay? Neutrophils they love to break down bacteria. So what happens is your neutrophils and your macrophages will come out and they'll actually undergo phagocytosis of the actual streptococcal bacteria. Now, once they undergo phagocytosis, two things will happen. If you guys have watched our inflammatory videos, our videos on inflammation, we've talked about how whenever the neutrophil will phagocytose the actual bacteria, it'll take it in and it'll utilize what's called lysosomes. Those lysosomes will then break down the bacterial cell wall, and then what it'll do is it'll exocytose all the remaining antigens. So what it's going to do is it's going to break that bacteria down, and through exocytosis, it's going to release these antigens. So it's going to release these antigens that freely circulate through the lymphatic circulation and into a regional lymph node, okay, within the throat. The macrophage is a little bit different. He's a little bit nicer. He's more polite. What he does is he engulfs the bacteria, right, breaks it down with the lysosomes, and then it activates the gene on chromosome number 6 to produce MHC2 molecules. And what will happen as a result of this is it'll activate the HLA2 genes, or the MHC2 genes on chromosome number 6, and cause it to produce a protein called an MHC2 molecule. And that MHC2 molecule that it's going to produce is going to harvest a particular molecule on top of it. So let's do this one here in brown. So here we're going to have this protein like this. And this is going to be called the MHC2 molecule. Presenting onto that, we're going to present that antigen that comes from the bacteria. And we'll present this here in that bluish color. So now it's going to have the antigen presented with the MHC2 complex. This is our macrophage. So neutrophils exocytose it. Macrophages are going to engulf it and present it with the MHC2 complex and the antigen. Now what will happen? You have some really important cells that are located within your lymph nodes. These are called T cells. Our T cells are really important because they have specific proteins that allow for them to recognize that MHC2 molecule. That specific protein molecule is called CD4. So it has a CD4 molecule which helps to be able to react with the MHC2. It has another molecule which is specific to react with this foreign antigen. And this is called a TCR, a T cell receptor. Now, based upon this interaction as well as co-stimulatory reactions between B7 and CD28, there's a massive amount of cytokines being released. We're not going to go over all those cytokines in detail, it's not necessary. But what I want you to know is there is going to be the massive release of cytokines by these T cells. If you really want to know, interleukin-1 is what stimulates this actual T cell, and the T cell will produce many different cytokines. Interleukin-2, interleukin-4, interleukin-5. The whole purpose of this is that these cytokines are then going to go and activate specific cells located in this actual lymph node. And this is going to be our B cells. So here we're going to have our B cells. So right here we're going to have the macrophage, right? So this is our macrophage. This is our T cell, our T helper cell. And then again, this is going to be our neutrophil. These interleukins, they stimulate the B cells, right? And what happens is these B cells, when they're hit with all of these different types of cytokines, what it does, it tells the B cells to start proliferating. So they undergo clonal expansion. And then it triggers them to differentiate. What does that mean? It means that they turn into what's called plasma cells. Plasma cells are really important cells. They have a lot of rough endoplasmic reticulum because they're protein-producing factories. And whenever these guys are differentiated, and they're also going to be stimulated by these cytokines, so let's actually draw an arrow there. These cytokines will also stimulate not just proliferation and differentiation, but it'll also stimulate antibody production. So now this plasma cell is going to start producing antibodies. And these antibodies are designed to do what? Well, they're designed to go and attack this actual antigen. And then tag it for what? To enhance phagocytosis of the macrophages, to activate the natural killer cells, to enhance the complement proteins, to produce membrane attack complexes, and to elicit more inflammation, to bring more white blood cells, more complements, more inflammatory mediators to this area to break down the bacteria. That's the overall goal. And 97% of the population will properly respond to this. However, 3% of the population, unfortunately, will have these antibodies directed to other tissues. For reasons we're not completely sure of, the only thing that we've been able to elicit out of this is that it might be related, it's specific in children. That's one thing. So one of the things that we've been able to elicit for the reasons why this can occur is it's specifically common in children. Peak age of 5 to 15 years old is usually the average age range. Another thing is we've seen it in situations of poverty and in areas of where there's overcrowding populations. So these are the common theoretical reasons of why we believe that this 3% reaction occurs. But now, guess what happens? These antibodies, we said that they're designed to be able to attack what? The proteins on the group A beta hemolyticus streptococcal bacteria. However, those proteins in our body, we have proteins that mimic that actual protein on these bacteria. In other words, it looks very similar. So our antibodies will love to attack those different areas that have proteins that mimic it. What do we call this? It's very simple. It's called molecular mimicry. So what's going to happen is, in that 3% reaction, we have this thing called molecular mimicry. In other words, it just means that if I have a tissue cell here, and let's say that I draw that bacteria, just a crude diagram here, all right? So here's my tissue cell, and here's the bacteria. I might have an antigen present on this group A beta hemolyticus streptococcal bacteria that is very, very similar to an antigen that I have on my own host cell. That's the problem. So where are these actual tissues and what are these proteins that are maybe mimicking the bacterial proteins? Well, one is in the skin. And what is the main protein in the skin? Keratin. So one of the big things that you'll see is that these antibodies will deposit and actually have an interaction with the keratin, right? It'll interact with the keratin within our keratinocytes, within our skin cells. That's going to produce specific skin lesions, and we'll talk about what skin lesions we'll see when we go over the different target tissues in more detail. The next thing is it can target proteins within inside of our actual central nervous system. You know, there's these really, really important structures within inside of our central nervous system called the basal ganglia. They're really important specifically for being able to coordinate movements, specifically preventing overshooting and undershooting of the motor movement, dampening the motor movements. They're really important with that. Well, they have proteins very similar, and they call these proteins ganglioside proteins. Gangliosides. The particular one is called lysoganglioside proteins, and this can produce what's called, we'll talk about in a second, but they call this Sydenham's chorea. And we'll go over what this means. The next thing is you have proteins in the heart tissue. One of the serious tissues that is affected here is it can affect the endocardium, the myocardium, and the pericardium, all three layers, so they call that pancarditis. But there's many different proteins here. So some of them, to name a few, is laminin. Laminin is a really important protein. Also, what's the proteins of the muscle cells? So you're going to have tropomyosin is a big one. Tropomyosin, myosin, maybe even actin, troponin. We can have some of these proteins being attacked. And that's going to lead to what kind of situation? We call this, when it affects all three layers, we call it pancarditis. Pancarditis. The last one is it can affect the proteins, particularly within our actual synovial joints, particularly the large joints, which have a protein in it, which is called vimentin. So it's called vimentin. And whenever this antibody attaches to the vimentin within the synovial joints, it produces what's called polyarthritis, and particularly migratory polyarthritis. And we'll go over that. Okay, so we should really understand what happens, again, with this whole pathophysiology. Bacteria has the opportunity to damage the tissue, right? It starts damaging the tissue, it triggers an inflammatory response, increases blood flow, permeability, more white blood cells, more complements come to the area. What specific white blood cells are going to be in this area in high concentrations? Macrophages and neutrophils. Macrophages and neutrophils engulf the bacteria. Neutrophils, they just undergo exocytosis of the remaining antigens because they break it down with the lysosome and reactive oxygen species. Macrophage engulfs it, breaks it down with lysosomes, and presents it on the cell membrane with the MHC2 complex, and then it takes it to a regional lymph node, where it presents it to a T helper cell, interacts via the MHC2 CD4 TCR antigen interaction, and releases a massive amount of cytokines that turn B cells into plasma cells, and stimulate the plasma cells to produce antibodies. Those antibodies are directed against the antigens, the M proteins within for the actual streptococcal bacteria. But there's other antigens in some situations, 3% of the population in children, impoverished areas, and in overcrowded populations, where those antibodies can attack proteins within our tissues that mimic the actual proteins on the bacteria, such as keratin within the skin, the ganglioside proteins like lysoganglioside proteins in our basal ganglia, the laminin, tropomyosin, myosin, actin, all these proteins within a heart tissue, and then the vimentin within the actual joints. And this is called molecular mimicry, okay? Now, what we need to do is we need to talk about a little bit more about this tissue damage, go over these in a little bit more detail, and then after that I want to talk about what's called the Jones criteria of how you'd be able to diagnose rheumatic fever. All right, so let's go ahead and move on now to the heart. All right, so like I said, it damages the heart tissue. Here's the thing. When those antibodies are directed against our heart tissue, 50 to 60% of the symptoms that arise from rheumatic fever in response to streptococcal sore throat or streptococcal pharyngitis is with respect to carditis. So again, just remember that 50 to 60% is usually going to be presenting within the symptoms of the heart disease. And this is actually one of the big ones because what can happen is rheumatic fever over consistent and recurrent attacks can lead to what's called rheumatic heart disease, which is no bueno, not a good thing, you don't want it, okay? And we'll talk about why. So let's go through here. We said that it affects all the three layers. Well, if you guys go back to your anatomy, what do we have? We have the pericardium first. So the first layer is going to be the pericardium. Now, just a little bit on your anatomy, what are the two layers of the actual pericardium? There's the visceral, and then there is the parietal layer. Now, what happens is in between, so here you're going to have this pink layer here, that's going to be our parietal layer. They're going to have that baby blue there, that's going to be the visceral layer. What's in between? In between is actually going to be serous fluid. There's going to be serous fluid, and this serous fluid is called the pericardial fluid. What can happen is whenever there is actually going to be inflammation of the visceral and the parietal pericardium, it's going to lead to these layers becoming inflamed. And whenever these two layers become inflamed, whenever the heart is going through systole, contracting, and diastole, relaxing, those two layers are rubbing up against one another and producing some intense inflammation, a really stabbing chest pain that we can feel called a pericardial friction rub. So one of the big things that I want you guys to remember here is that whenever these two layers rub up against one another, it produces a very important thing called a pericardial friction rub. And one of the important things about a pericardial friction rub is you can hear this upon auscultation. So if you're auscultating and you're listening to the heart, you'd be able to hear that scratchy sound of a pericardial friction rub. Okay? So that's one thing, is it's going to produce pericarditis. Pericarditis by causing inflammation of the visceral and the parietal epithelial tissue that is going to be making up the pericardium, leading to inflammation, rubbing up against one another, producing friction that leads to the pericardial friction rub. And this is a stabbing pain, very, very painful. The next and the most serious one is the next layer here. This muscle layer, that cardiac muscle tissue called the myocardium. So the myocardium is really important, and the reason why is it is the pump of the heart. It's responsible for contracting and ejecting blood out of the heart. What happens is those antibodies, again, can start damaging the tissue of the myocardium. And you can imagine that whenever it produces this damage, it produces a specific type of necrosis. You know what they call that? They call this fibrinoid necrosis. Fibrinoid necrosis. There's a lot of fibrinogen deposited into the area. But another thing is there's a lot of inflammatory cells into the area. What you'll actually see is you'll see what's called, if you take a slide, you'll have what's called Aschau bodies. Okay, so let's say I took a slide here and I looked at the slide. What I would have, histology-wise, is I would have this area of fibrinoid necrosis. So let's say that here is going to be this area of fibrinoid necrosis. So we're going to have a lot of fibrinogen deposited into this area here. Okay? The next thing you'll have here is you're going to have these things called Etiology bodies, Etiology bodies, or Etiology cells. And all these are like these caterpillar-like macrophages. So you're going to have these caterpillar-like macrophages, and those are called your Etiology cells. Another thing you'll have in the area is you're going to have a lot of T cells in the area. So you're going to have a lot of T cells. So what is this whole thing here called? This entire fibrinoid necrosis, which consists of a lot of fibrinogen, some T cells, and some Etiology cells, which is going to be these large caterpillar-like macrophages. This is called Aschau bodies. So this is called Aschau bodies. Okay? Why is this very serious? Because imagine if you produce a lot of fibrous tissue with a lot of this inflammatory mediators in the area and a lot of the actual immune system cells. Is this tissue able to contract? No. So what's going to happen if it starts becoming more widespread? It's going to lead to the myocardium not being able to contract enough. What does that mean then? Remember when we talk about cardiac output, that you have what's called preload. So preload is the degree of stretch. Well, you're going to have a lot of fibrous tissue. It's going to decrease the stretch now. Your contractility is going to decrease because now you're losing a lot of the actual myocardial cells. As a result of that, that's going to decrease the stroke volume. If you decrease the stroke volume, you decrease the cardiac output. Why is this dangerous? Because over time, if it continues, it can lead to congestive heart failure. And that is no bueno, right? We don't want that. And that is the severe, really problematic thing here with the myocardium, okay? So myocardium, you get fibrinoid necrosis with Aschau bodies. Over time, it can lead to a decrease in the preload, which is a decrease in the stretch, a decrease in the contractility because of loss of myocardial cells, a decrease in the stroke volume, decrease in the cardiac output, and then eventually, over time, it can lead to just complete deficiency in the pump adequacy, and that can lead to congestive heart failure. The last thing is it can affect the endocardium. So it can also affect the endocardium. Now, the endocardium is the inner lining of the heart. One of the big things is it loves to attack the valves. Okay? It loves to attack the valves. So what does it do to the valves? Let's pretend here I have like a drawing here of the valve. So I'm going to kind of put a valve right here, right? And then we're going to put a valve right here. What happens is, and you have this thing connecting the two, you have an annulus fibrosus ring. So here is going to be a ring. This is going to be the annulus fibrosus ring. And I'm taking a section. I'm taking a section here of the heart valves. So here's our heart valves. What happens over time, and here we'll have our chordae tendineae. What happens over time is that these valves start getting what's called rheumatic vegetations, okay? Rheumatic vegetations and a lot of inflammatory cells into this area. So this actual valve is going to become swollen. It's going to have a lot of edema. So the valve will become swollen. So there's going to be edema consisting of a lot of inflammatory infiltration, T cells, macrophages, right? You're going to have these things called rheumatic vegetation. So what are these things here? They're called rheumatic vegetations. Another thing is over time, these valves, as the inflammation occurs, it activates particular cells. You know, we have these things called fibroblasts, and our fibroblasts, when stimulated, love to produce a lot of collagen and fibrous tissue. What happens is this collagen starts actually causing this actual valve to become thicker. So now we have the valve becoming inflamed, we have vegetations, we have a lot of inflammation, and now we're activating fibroblasts to thicken the valves. And here's where it gets really bad. It can get to the point where if this is recurrent episodes of rheumatic fever, where this actual fibrous tissue and this collagen thickening can lead to stenosis of the valve. Okay, so what can happen with this? It can actually over time lead to stenosis. And also it can lead to regurgitation. Right? Now, what valves are primarily affected within the endocardium? It's specifically the left heart. What is this valve right here? The mitral valve, right? What is this valve right here? The aortic valve. So what you'll notice over time is that it's going to specifically target two valves. One is the mitral valve or the bicuspid valve, and the other one is going to be the aortic semilunar valve. Now, again, what we know, the severe thing with this is that it becomes swollen or edematous valves. They can actually start causing rheumatic vegetations. There's a lot of immune cell infiltration. There's fibroblast activation, which is going to produce fibrous tissue that is actually going to thicken the valves, make them more stenotic, particularly the aortic valve. And the mitral valve, it can produce mitral valve stenosis or regurgitation, or aortic valve stenosis and regurgitation. Another really bad thing is it produces these types of fibrosis that we call commissural fusion. It can literally cause the actual valves, if you kind of imagine it like this. Let's say I draw kind of an upper view of a valve. So here I'm going to have, let's say here is one valve flap, and here's another valve flap right here, and here's the hole between the two. What can start happening is this is supposed to be the actual hole where the actual blood is flowing through. But over time, because of that fibrosis, it can start producing fusion here at the edges. And that is called commissural fusion. So this can lead to what's called commissural fusion. Now you can imagine how serious this can be. It can lead to the point where the valve does not even open, and that is not good. Another thing that can happen over time if there's repeated bouts of rheumatic fever is it can lead to what's called subacute bacterial endocarditis. So here's the big thing that I want you to remember to take away from this for the rheumatic condition is that over time the thing that you worry about is subacute bacterial endocarditis. This is the scary thing with this condition, because over time with repeated inflammation and attacks, it's going to lead to the valve becoming so damaged that eventually it starts leading to actual septic vegetations, bacterial vegetations that can then break off, lodge within the pulmonary vessels, lodge within the cerebral vessels, and become extremely dangerous and fatal. Okay? So that's why when we talk about management, we'll talk about prophylaxis if there is recurrent attacks to prevent subacute bacterial endocarditis, because that's our fear. Okay, so that's how we can affect the actual heart. So that's the pancarditis effect. The next one is how does it affect the actual central nervous system? So if you remember, inside of the central nervous system, we have a couple different areas, right? We're not going to go into crazy detail, but if you know, we have a specific area here, which is going to be really important, and this is going to be called the lentiform nucleus. So you know you have what's called the lentiform nucleus. And the lentiform nucleus is made up of two things. The putamen, which is this outer part here. I'll highlight that in this bluish color here. So the outer part here is the putamen. And then this inner part here is broken into two layers. That's called the globus pallidus. So the globus pallidus externus is this green one, and then the globus pallidus internus is this most inner one. These are really, really crucial part of the actual basal ganglia. It's called the lentiform nucleus. Another important structure here is going to be what's called the caudate nucleus. So another one is going to be what's called the caudate nucleus. So caudate nucleus. And another important area here is going to be just below the thalamus. Let's put my thalamus here. Is going to be called the subthalamus. So that's another really, really important structure here. Right below the thalamus is going to be what's called the subthalamus. Now, we already said that there's proteins like the ganglioside proteins that the antibodies come in and attack. So they attack the lentiform nucleus, the caudate nucleus, the subthalamus. All of these are important with being able to control what's called our direct and indirect pathways, which help to prevent the overshooting of the movement, the undershooting of the movement, and help to provide smooth motor movements, right? Well, if we freak that up, it's going to start really messing with our movements. Now they're going to be what's called really jerky, because what happens is they help to play a role within preventing like unwanted motor movements. So now what we're going to have is we're going to have damage to these areas. And that produces a condition that we refer to as Sydenham's chorea. And this affects 3%. This is about 3% of the symptoms that arise from rheumatic fever. Now, what this characterizes is it's uncontrolled kind of jerky movements. Uncontrolled jerky movements. So what is that? Let's write this down here. Uncontrolled, rapid, jerky movements, and particular areas of the body. One is the face, also the tongue, and the upper limbs. Okay, so it's going to produce these uncontrolled, jerky, rapid movements of the upper limbs, the tongue, and the face. So one more thing I want to make sure that I mention before we move on to the joints is I wanted to come back to the heart. Remember we said that there was this stenosis, possible stenosis or regurgitation from all of the stuff what we already mentioned. I just wanted to make sure that we don't forget another thing that can happen over time is this chordae tendineae can become really thickened. And that also can become a problem with contractility as well as the valvular function. So over time, what can happen is this can lead to chordae tendineae thickening. So let's write that down there. The chordae tendineae thickening. And again, this is just going to add on to the fact of the mitral valve issues, particularly with the stenosis or regurgitation, just adding on to that fact, okay? All right, so the next thing we know is we said that it can actually attack the joints. This is the really, really important one. Some of the first signs that usually appear. Rheumatic fever can usually appear about 1 to 4, 1 to 5 weeks post-streptococcal pharyngitis. Usually the first signs to arise is a fever, rheumatic fever, and joint pain. Now, one of the big things, about 75% of the cases, 75% of the symptoms that you usually develop is going to be via this polyarthritis. So one of the big things that you'll see here is what's called polyarthritis. So it's going to produce a lot of tissue damage here, right? We said that it has the vimentin that it's very similar to. So it's going to cause inflammation of the synovial joints. Which synovial joints? Particularly the larger synovial joints. So obviously this would be your hips, your shoulders. Those are going to be some of the ones that are really, really affected here. Another situation is in here, let's put that down. So it can really affect the hip joint, and it can also affect the shoulder joint. Another thing is that it's migratory. Okay, so it's migratory. It can spread. Now this is important to realize that polyarthritis is different from the normal just kind of like arthralgia that we feel, right? this is going to involve a lot of large synovial joints. It's going to be migratory. It's not just going to be pain over the joint. All right, so that's really important to realize. So 75% of the symptoms usually develop with this polyarthritic pain of large synovial joints, hips, shoulder, and it can be migratory. All right? All right, so now we know that they can develop the tender, joints, the polyarthritis, large hip joints, migratory. The last one that I want to talk about for the major criteria here is for the skin lesions. Now, it can affect the epidermis and the dermis. What it does is it leads to this really interesting rash. This rash is called an erythema marginatum. So we call this erythema marginatum. It's kind of like a annular concentric ring-like rash. Okay, what do they call this? They call this erythema marginatum. And this can appear on the skin, so it's a skin lesion, and it particularly occurs on the extremities, so upper and lower extremities, and it can appear on the trunk of the body. Okay, so the trunk of the body and then the upper and lower extremities. The next thing is you can also develop this collagen deposits. So you can develop these collagen deposits, particularly around the area of the subcutaneous tissue. So now you're going to get these collagen deposits. And these things are really, really interesting. They are called subcutaneous nodules. So there are a lot of collagen deposits that can attach to the fascia and the underlying bone tissue. And again, these are called subcutaneous nodules. And they usually appear on the extensor surfaces of our body. So like the back of the wrists, they can appear on the elbows, usually on the side of the elbow is another common area. So the elbows and the knees. But in general, you can find these in a lot of places. Sometimes they can be really severe and appear on the actual vertebral column. Okay? So these are some of the big signs that you'll see here, okay? So just, it's going to see your skin lesions, erythema marginatum, which are going to appear in the extremities and the trunk, the subcutaneous nodules, which are going to be collagen deposits that can be attaching to the fascia, underlying bone, back of the wrist, elbows, knees. Your polyarthritis is another important one, which can affect the larger synovial joints, hip, shoulder, and again, remember that it's migratory. All right, so the last thing is we've already been able to notice how the pathology all plays out. I think we beat that like a dead horse. So now what we need to do is we need to kind of get into how we would diagnose it, just based upon our clinical understanding. Okay, so what we do is we follow the specific criteria. They call it a Jones criteria. Let me write this over here for a second. So we have to follow this thing called a Jones criteria. And what this criteria says is that in order for us to kind of be able to make a diagnosis, we need an option. We have an option. We have two options here. One is we need two major criteria, or we need one major criteria plus two minor criteria. And I'll explain what that means, okay? All right, so here's a nice little way of being able to remember this. There's all these special ways out there now that we can kind of figure things out. So Jones kind of tells us our actual major criteria. So here's what I want you to remember. Jones, J for joints. What's that? Polyarthritis. That's one of the big signs. So O, if you can kind of think about it, it kind of is myocardium. It's the heart. So for the O, we're going to really kind of go to myocardium. Another thing I've also heard is that if you look at the O, if you put a little dimple into it, it can look like a heart. So you can also think here, myocardium, right? So that's another important one. But in general, don't just remember that it's just the myocardium, it's all the heart layers. So this helps you to identify this part, but remember that it's really pancarditis. The next one is N. N for nodules. And the nodules is going to be particularly the subcutaneous nodules. E for erythema marginatum. which is that skin lesion that we saw. And S for Sydenham's chorea. S for Sydenham's chorea. Okay? So the Jones joints, O for myocardium, kind of looks like a heart if you make a little dimple. Pancarditis. Nodules for subcutaneous nodules. E for erythema marginatum. Sydenham's, or S for Sydenham's chorea. All of these are our major criteria. So all we would need is 2 of these, and we could diagnose rheumatic fever. So some of the minor criteria that we want to possibly consider is, remember, it can produce fever. It can activate our hypothalamic area, right, the hypothalamus, and trigger the actual resetting of our body's thermostat. So fever is a really, really important one. Another one is going to be arthralgia, which is just kind of your joint pain. All right, so arthralgia. Another one, and this one's really kind of interesting, is because it can affect the heart, right, the pancarditis, it can alter with the electrical system, the conduction system of our heart. And what it can do is it can produce a prolonged PR interval. So prolonged PR interval. So if you know here, you have your P wave, right? At the beginning of the P wave, you have here, at the end of the P wave, you go here, PR segment, and then from here, we go QRS wave, and then T wave. So the PR interval is from here all the way till here. That segment there is going to be prolonged. So there's a prolonged PR interval. Here's another really good one. Remember we told you that over time, it can start to cause valvular dysfunction. So another big issue here, so we have fever, arthralgia, prolonged PR interval. Another one is it can start to produce valvular dysfunction. Particularly what valves again? Mitral and aortic semilunar valve. And what's another big one? Whenever there is inflammation, this kind of inflammatory condition, our liver responds to that by producing 2 things. One is it produces what's called C-reactive peptide. It's a acute marker for non-specific types of inflammation. It can be slightly specific for myocarditis or for fevers, bacterial infections, and things of that nature, but it is going to be a marker of acute inflammation. So CRP levels would be elevated. Okay, so if we did some labs, right, we would find that their CRP levels would be elevated. Another thing is the liver also makes a protein called fibrinogen. What happens is when we do a test, we do what's called the erythrocyte sedimentation rate. So what you do is you take red blood cells. Actually, let me go ahead and explain this to you. So how this erythrocyte sedimentation rate works really quickly. So imagine I take red blood cells. I take a test tube. Right, here's my test tube. I take some red blood cells, right? And when I take these red blood cells, I'll put them in a test tube and I'll let them fall to the bottom of the test tube by gravity. In situations like an acute inflammation, our liver produces a protein called fibrinogen. What happens is fibrinogen actually causes a lot of these platelets to start sticking together. And red blood cells, these red blood cells start sticking together and they kind of make like this little linear like tube, like they stack up on top of one another. This is called a rouleau formation. Now, why is that important? Because as this fibrinogen is actually causing a lot of these to stick together to form this rouleau, now look at the density of this. It's going to have a lot of proteins weighing on it. It's more aerodynamic. It can actually fall a lot faster. So because of this, that is actually going to fall to the bottom of the test tube a lot faster than normal. The rate at which the red blood cells fall to the bottom of the test tube is called the erythrocyte sedimentation rate. But if you increase the number of fibrinogen molecules based upon inflammation, right? So inflammation stimulates this, produces fibrinogen, causes the fibrinogen to stick to the red blood cells, form a rouleau, drops down to the bottom. What happens to the ESR? It goes up. So that'll show us that there is some signs of inflammation. So if we did like a test like that, we would find that they would have an elevated erythrocyte sedimentation rate. Now this is our minor criteria. So all we would need to be able to come up with a suspicion of possibly having rheumatic fever is 2 major criteria or 1 major criteria and 2 minor criteria. Other things that you can do to help with the diagnosis of this is you can do some tests, because another thing, actually one more thing I forgot, and this is really important, I'm going to put it over here on the side, is you have to have evidence of post-strep infection, right? Because we said that this is most commonly due to strep throat. So you need evidence of this. So what would you do to determine that? Well, you could do what's called a RAT, a rapid antigen test. And all it does is you just do a quick test where you determine to see if there is any of the antigens present on the streptococcal bacteria. That should be positive. So you should have a positive rapid antigen detection test. Another thing is you should have a positive culture and sensitivity. So you should culture, do a culture. If you get a culture, you'll find that they'll have a positive culture and sensitivity. Another thing that we can do is we can test their anti-streptolysin O titers. So we'll look to see that they're positive or have elevated anti-streptolysin O titers. Okay, anti-streptolysin O antigen titer elevation. These are some of the things that we'll actually do look at. Okay, so again, 2 major criteria or 1 major and 2 minor criteria, and one of the big minor criteria is usually you need to have evidence of the post-streptococcal infection by doing either a rapid antigen detection test, positive culture and sensitivity, and looking at their titers for the anti-streptolysin O antibodies. Okay? If you guys like this video, please hit that like button, comment down in the comment section, and please subscribe. Also, go check out our Facebook, our Instagram, even our Patreon account. If you guys can actually donate $1, we would truly appreciate that. Also, go check out our GoFundMe page down in the description box. If you guys can donate there, we would truly appreciate it as well. And as always, Ninja Nerds, love you guys, and until next time.